Hi, my name is Hobart Lee, and welcome to the Primary Care Updates. Our learning objectives today are to identify new major guidelines which impact family physicians or primary care doctors, recognize updates and in the diagnosis and treatment for diseases and illnesses which are commonly cared for by primary care physicians, and appreciate the evolving medical literature around some hot topics and issues that receive recognition from the lay press. You see, we have lots of topics to cover today. The goal is not to go in depth in any one topic, but just to pique your interest, and the references will be fully available at the end of this presentation, so you're welcome to read about them in more depth if you're interested. So let's talk about opioid and chronic opioid medications. So we know that this is an issue. There's been a 30% increase in emergency department visits for opioid overdoses. You can see mostly in ages 25 and older. So what are some things that we can do to help mitigate that risk? So certainly checking your state prescription drug monitoring programs known as cures here in California, and that often will help determine a patient's drug history. Consulting the CDC guidelines regarding prescribing opioids can be helpful. Educating patients, especially around treatment options like medication-assisted treatment, and using the CDC app for really quick information around prescribing guidelines. This was a study done in Massachusetts by Weiner et al., and they looked at 17,000 patients who went to the emergency department for treatment of non-fatal opioid overdoses. And you can see here that 5.5% of patients died within 1 year of that emergency department visit. But if you look at this graph, you can see there were the number of deaths especially spiked right after that emergency department visit. So 5% of all deaths occurred within 2 days of the ED discharge. And so I think this is very important that as we are seeing patients either in the emergency room or in our outpatient clinics after they've been discharged, to think that that first 48 hours after a non-fatal opioid overdose, we have a lot of education and work to do to help mitigate that patient's risk. And so things like naloxone, buprenorphine, referrals to MAT are all things that we can do to help decrease this patient's risk for potential mortality related to overdose. This was another trial. Dr. Krasizik looked at this, 139 patients in Maryland. These are emergency department patients again. And what she found was that the mortality was 69.2 per 10,000 patients, which is 6 times higher than any other emergency department patient. This includes patients who are there for sepsis and heart attacks and strokes. And so you can see here the mortality risk is really quite elevated for these patients. And the 3 greatest predictors of overdose were: 1, having a history of 3 or more non-fatal overdoses, an opioid use disorder plus another substance use disorder like alcohol, or a prior non-fatal heroin overdose. So when I think you see these types of history in your patients who have been discharged from the emergency room for an overdose, that should be a trigger to you that these patients are at very high risk for mortality, and that urgent referrals and close PCP follow-up and harm reduction are really our goals here to try to mitigate this patient's risk. So let's talk about Tramadol, because often we think of Tramadol as being a semi-synthetic drug, maybe safer than some of the other medications like hydrocodone or oxycodone. And so this was a trial in the UK looking at 88,000 patients with osteoarthritis. And what Zhang found was that Tramadol was associated with higher mortality when you compared it to naproxen with a number needed to harm of 109, diclofenac with a number needed to harm of 62, and celecoxib with a number needed to harm of 82. This last medicine that they compared is not available in the United States, so you don't have to worry about that. But you can see here that Tramadol, when we compare it to some of the other NSAIDs, does seem to increase your risk of mortality. And when they compared Tramadol to codeine, you can see here that essentially the risk is about the same. And so I think when we think about Tramadol, especially as it comes to Tramadol mortality, the best way to think about this is maybe very similar to how we think about codeine in terms of mortality risk. Okay, this was another trial looking at, another retrospective study looking at 400,000 Medicare patients who received acute pain medication after surgery. And what they found, interestingly enough, was that if you were prescribed Tramadol after your acute care surgery, as opposed to hydrocodone or oxycodone, you were more likely to be on Tramadol at 6 months than those other drugs. And so we're not exactly sure why that is, but you can see here that Tramadol seems to cause persistent opioid use compared to some of those other short-acting opioids with a number need to harm of 270. We're not exactly sure why this is, but this may be coming from this idea that we think of Tramadol as being, safer, right, than these other medications. And because of that, we're more likely to continue these prescriptions after surgery, while for other medications like hydrocodone or oxycodone, we're much more likely to try to taper them off and switch them or stop them. Okay, just as a review, so a lot of times I think we say, okay, well, let's prescribe gabapentinoids as an adjunct or a replacement for opioids. But just remember that the FDA diagnoses for approval for gabapentin are post-herpetic neuralgia. For pregabalin, it's post-herpetic neuralgia, diabetic neuropathy, spinal cord injury, and fibromyalgia, right? And so when we prescribe gabapentinoid for chronic non-cancer pain, most of the time we're using it off-label, right? Now, we do know that gabapentin reduces pain in about 50%, by 50% in diabetic neuropathy with a number needed to treat of about 6. So really good evidence to use gabapentin for things like diabetic neuropathy, but it is an off-label use. And we have very limited evidence for other neuropathies like fibromyalgia or things like fibromyalgia. And really, there's no evidence for things like low back pain, radiculopathies, or acute zoster pain, right? Other common things that we prescribe gabapentinoids for. When we think about the difference between gabapentin and pregabalin, they both work on these voltage-dependent calcium channels, but the half-lives are about the same, 5 to 7, but pregabalin is absorbed faster and has a higher bioavailability. The bioavailability of gabapentin is about 30 to 80% depending on the dose, but the bioavailability of pregabalin is probably above 90%, right? We reach peak concentrations higher and faster in pregabalin in about an hour versus about 3 hours for gabapentin, right? But just note that there really is no direct comparisons for chronic non-cancer pain between gabapentin and pregabalin. Okay, so is pregabalin helpful for acute post-surgical pain? This was a study looking at 80 patients who were scheduled for a donor nephrectomy. And afterwards, they prescribed them pregabalin, which did decrease their opioid usage, but it also seemed to affect their executive functioning. So when they did standardized testing post-op day 3 and 5, they found that pregabalin negatively affected their executive functioning, which has been related to hospital falls in other studies, including inhibition, the ability to focus, and working memory. So while pregabalin may be effective for reducing opioid usage, there does seem to be a negative effect related to executive functioning, at least in the post-operative setting. Okay, so I think as another adjunct, a lot of times we talk about using compounded topical medicinal creams to try to help reduce pain. And so this was a study of 399 patients with localized pain. This was a VA study. And they looked at 3 different topical pain medications: a neuropathic pain cream, a nociceptive pain cream, and a mixed topical pain cream, right? And you can see the individual ingredients, including things like ketamine and gabapentin and clonidine and lidocaine and baclofen and cyclobenzaprine and things that we commonly will mix into these sort of compounded topical medicinal creams. Unfortunately, when they looked to see if there was a difference between that and placebo, they found that none of these medications were more effective than placebo. The one caveat I will make is that they did not use capsaicin, which is a common topical pain relief medication, because they felt like that would cause unblinding. And for those of you who've used capsaicin, kind of know that it's very, most of us know when you've used it because you can feel the heat associated with that medication. And so that may be the one medication that might be helpful. The other thing I will note is that the AAFP and the ACP produced a joint guideline in November of 2020, and they really say that topical NSAIDs for acute pain, non-back pain, musculoskeletal injuries, acute, not chronic, really topical NSAIDs with or without menthol gel is kind of first line therapy to relieve symptoms, improve pain, improve physical function, and improve patient satisfaction. So think about using topical NSAIDs maybe as a first line for, again, acute pain, non-low back, musculoskeletal injury. Okay, do mind-body therapies work to reduce chronic pain? So the answer is yes. So things like meditation, which include things like mindfulness, hypnosis, which is kind of this altered state of consciousness, therapeutic suggestion, which is suggestions to change thoughts, emotions, and sensations without hypnosis, and classically our CBT, which is logic to challenge negative thinking patterns and promote adaptive behavior. So all of those had moderate to large effect sizes in controlling and reducing pain. And you can see here that meditation and hypnosis and CBT specifically also reduced opioid-related outcomes like reduced dosages of opioids, reduced cravings, and reduced misuse of opioids. So I think this is good evidence. This is a meta-analysis over 60 studies with over 6,400 patients. And so I think this is good evidence to suggest that in our chronic opioid patients who are struggling with chronic pain, that incorporating behavioral health techniques like meditation, hypnosis, CBT can be helpful in reducing pain and also reducing their opioid usage. They also studied things like guided imagery, which is the active imagination of visual, auditory, and somatic sensations, and relaxation, which is just using the mind to relax the body. And unfortunately, those two did not show significant differences in reducing pain. Okay, so let's switch gears here and talk about COPD. So how can I know which COPD exacerbation patients will benefit from antibiotics? So the answer is C-reactive protein could be helpful here, right? And so classically, we've used the Anthonison criteria, right? So increased dyspnea, increased sputum volume, or increased sputum purulence, right? And if you've had 2 out of 3 of those, we kind of say, okay, you likely have an infection and we'll give you antibiotics. But this was a study in the UK, 649 patients. And what I like is this was a primary care outpatient setting. And these are patients with COPD exacerbations, and they were randomized to CRP, guided therapy, or usual care. In a CRP less than 20, they were unlikely to benefit from antibiotics. A CRP greater than 40, they were likely to benefit, and there was kind of this gray zone in the middle. And what they found was that in the CRP guided group, that those patients got less antibiotics with a number needed to treat of around 5. But when they looked at the outcomes, their COPD health status was similar in both groups. Hospitalization rates were similar in both groups. And so I think this is a good evidence that there may be more objective ways for us to look at COPD exacerbations and determine which patients might benefit from antibiotics. Now, I will mention that this study was not powered to look for possible treatment failure, and that point of care CRP testing really isn't widely available in the United States. And so maybe this is something that's coming down the pipeline, or maybe something you can use for select patients who would prefer not to be on antibiotics, and you have the ability to get a lab test like C-reactive protein fairly quickly. But this is something that could help sort of distinguish who would benefit from antibiotics and who would not. Okay, what's the best way to treat and prevent exacerbations in mild intermittent asthma, right? And so the answer here may be a combination of an inhaled steroid and a long-acting beta agonist as needed, right? And so this was a study looking at 668 patients with mild intermittent asthma, and they kind of randomized them to kind of 3 different groups. One group was a group of inhaled corticosteroid and a long-acting beta agonist as needed. Another group was kind of albuterol or short-acting beta agonist as needed, kind of our traditional standard of care. And one group was given inhaled corticosteroids daily, budesonide daily. And what they found was that the inhaled corticosteroid and long-acting beta agonist group, the budesonide formoterol group, had reduced exacerbation risk, which was greater than just the short-acting beta agonist group, the albuterol group. And that the inhaled corticosteroid, long-acting beta agonist group had less severe exacerbations than those who were using the inhaled corticosteroid daily. The inhaled corticosteroid daily group did have better daily symptom scores, right? Now, I do want to mention very clearly that this budesonide formoterol is off-label use in the United States for mild intermittent asthma or mild persistent asthma, right? And that really in the United States, the budesonide formoterol really only comes in an MDI formulation, while in the trials they used a dry powder formulation. And so that may be another difference between the effectiveness in the United States versus in other countries. The adherence in this trial was around 56% to these medications, which is really good for an asthma trial. And so that may be another consideration, which makes this unique. A similar study, this is called the practical study. This was in New Zealand, 885 patients with mild asthma. 70% of these patients were already taking inhaled corticosteroid. But again, they randomized them to budesonide formoterol as needed, budesonide daily, or a short-acting beta agonist as needed. And again, you can see here that the budesonide formoterol, or the inhaled corticosteroid plus the long-acting beta agonist as needed, they were noticed to have less severe exacerbations. They used less inhaled corticosteroid, and it really seemed to benefit those patients with very infrequent exacerbations, maybe those who have 0 to 1 exacerbations a year, right? And so I think, so what can we take away in terms of a summary? So should you use an inhaled corticosteroid plus a long-acting beta agonist as needed for mild intermittent asthma or mild persistent asthma? So in 2007, the NAEPP, which is really our national guidelines here in the United States, don't suggest this, but as you can see, it's kind of an old guideline. The 2019 European guideline does suggest that this is a good option for patients, but you should recognize that this is off-label use, not approved, FDA approved for indication, and it really hasn't been studied in kids under 12. Lastly, if you do want to do this, please recognize that the drug used was formoterol, which has a faster onset than some of our other long-acting beta agonists that we commonly use, like salmeterol, and that we would only be able to prescribe the MDI formulation in the United States versus the dry powder formulation, which is the one that was used in the trials. Now, finally, I will mention that the NEAPP came up with an updated guideline just this past year in 2020, and they do say that for ages 12 and older, for mild persistent asthma, the expert panel says you can use a daily you can use a daily low-dose inhaled corticosteroid and an as-needed short-acting beta agonist, or you can use them concomitantly, right? You can use an as-needed short-acting beta agonist and an ICS for worsening asthma. So it does seem to be an option for patients who have mild persistent asthma and would like to use an inhaled corticosteroid and a long-acting beta agonist as needed for the treatment. Okay, I want to harken us back here a little bit to EVALI. So what is EVALI? So if you remember what EVALI was e-cigarette vaping product use associated lung injury. This was way back when. I just wanted to comment about this. It has become less of an issue as the formulation of e-cigarettes has changed. But remember, the definition was you had to have used an e-cigarette or a vaping product within 90 days. You need to have a pulmonary infiltrate either on chest X-ray or CT, and you need to have the absence of other pulmonary infections on workup, including like a negative RVP, a respiratory viral panel, a negative influenza test, right? And really no other plausible causes, right? But if you could see here, just as a comment, e-cigarettes are really commonly used by youth, right? And you can see here 4.9% or almost 5% of middle school students acknowledge having tried e-cigarettes or vaping products. And that 20% or 21% of high school students acknowledge this as well. So a lot of our young people are using this, and I think it's important for us to ask about. really, the treatment is kind of really tricky and not really well known, but if you do see them in the outpatient setting, frequent follow-up, maybe every 1 to 2 days, is really kind of recommended to monitor these patients. Corticosteroids as an outpatient is really quite controversial. It's not quite known whether they'll help people in the ambulatory setting. Certainly in the hospital, a lot of patients were benefiting from things like methylprednisolone, given for maybe about a week while they were hospitalized. Giving antibiotics or antivirals for possible infectious processes, it's again kind of unknown. And by expert opinion was recommended to kind of repeat imaging or spirometry in 1 to 2 months after their acute treatment to kind of see if there were any chronic effects from sort of the lung damage. Okay, moving on here, when should patients take their anti-hypertensive medications, right? So as a question here, what do these medications have in common? Loratadine, simvastatin, famotidine, prednisone, aspirin, and lisinopril, right? And the answer is that these medicines are all recommended to take at night versus the daytime, right? And so this was a trial by Hermida, the Hygeia chronotherapy trial. And that is a picture of the Greek goddess Hygeia, the goddess of health. But anyways, this was a trial looking at patients, 19,000 patients, about average age was 60 years old, 45% were female, 24% of these patients had diabetes. And what they did was the average office blood pressure of these patients was 149/86. And what the intervention was is they just had patients take all their blood pressure medicines at night versus during the morning. And what they found was that the primary outcome of cardiovascular death, MI, revascularization, heart failure, and stroke was reduced by about 45% relative reduction. So quite an impressive reduction with a number need to treat of about 19 over 10 years. And so all they did was just say, take your blood pressure medicines at night versus the day. The adverse events were similar in both groups. And I think this idea here is there is a phenomenon known as dipping and non-dipping. So most of us, when we sleep, our blood pressure drops, but for some patients, it does not. And they are known as non-dippers. And their lack of blood pressure dropping while they're sleeping seems to be really, really dangerous. It contributes quite a bit to their cardiovascular risk. And so by having them take their blood pressure medicines at night seems to be effective in terms of trying to help their blood pressure relax while they're sleeping. Now, interesting enough, they made no comment about diuretics. And so apparently they told their patients to take even their diuretics at night, which is something we commonly avoid because of the increased need for urination. But that's something that they didn't really comment on. And so this is a very interesting trial. It's something that I've sort of incorporated into my own practice, just asking patients to take their medications, their blood pressure medicines at night versus the day in hopes of gaining some benefit to these outcomes as mentioned. Okay, is statin therapy effective in children and in the elderly? So this was a trial looking at 214 kids with familial hypercholesterolemia. And what they found was that there was 99% cardiovascular disease-free survival in children versus 74% of their affected parents. And the mortality was 0% in kids versus 7% of their affected parents, all who died under the age of 40. So I think this is evidence that statin therapy can be effective in kids. I do want to make the comment that this was only looking at familial hypercholesterolemia, not looking at hypercholesterolemia in kids who are obese or have other sort of secondary causes. And the other thing I'll comment is that there was really no morbidity data looked at in this trial. Things looking at like teratogenicity risk for females who are of childbearing age and such. So I do think that this is something that does need to be looked at. But in select populations, it looks like statin therapy may be effective for kids. I do want to mention statin therapy in older patients. So this was a trial, most statin trials look at younger patients. And this meta-analysis really looked at and found that only about 8% of trial patients, or about 14,000 patients, are above the age of 75. And so when they looked at this, what they found was that if you wanted to prevent one vascular event in the age group greater than 75, the number needed to treat was 200. And that there was really no change in even vascular mortality above 75. and that there was really no statin benefit for primary prevention, so primary prevention in age groups greater than 70. So there was another trial more recently in November of 2020, and this was including 21,000 patients, and this included those patients that we just talked about. And again, what they found was the mean age was 79, 51% were men, and there was a reduction in cardiovascular events, but really no change in non-cardiovascular death and overall mortality in treating patients with statins, right? And just to recognize that the majority of these trials are secondary prevention trials, so patients who have already documented cardiovascular disease, not primary prevention. So if you ask me, most of my patients fall into the primary prevention. They haven't had a heart attack or stroke or documented cardiovascular disease yet, and I'm trying to reduce that risk. And it seems like, especially as patients get older, the documented benefit seems to be quite less and maybe not there at all. This was another trial, Yebbio looked at this and was trying to figure out from a primary prevention model, if we assume a 60% probability of net benefit, and the benefit is to really try to avoid cardiovascular disease. If we know that the known harms are myopathy, liver dysfunction, incidental diabetes, they tried to create a primary prevention model and said, what makes sense? At what risk do patients really benefit? And what they found was, you can see here at age 40, your 10-year ASCVD risk really needs to be above 14% for you to benefit. And at 70, it needs to be above 21% for you to benefit. And you can see the corresponding values if you're a female. And so these are much higher than the things that we commonly quote, which is like 7.5% or 10% as being kind of these cutoffs for starting medications. And so I think this is, again, more evidence for us to kind of really think about primary prevention and what is the right risk level. And certainly that medications may not be as effective as thinking about things like lifestyle, right? Our diet, our exercise, the choices that we make, things here that we are really known for here at Loma Linda, and things that we can advocate for our patients on a daily basis. Okay, switching gears again, what are the benefits of SGLT2 inhibitors in diabetes, heart failure, and kidney disease? And so no surprise here, but if you look at diabetics, SGLT2 inhibitors are really quite, have robust data around mortality, which is different than some of other medications. So this is from Scandinavia. They looked at 21,000 patients from a national registry. They compared SGLT2 inhibitors versus DPP4 inhibitors of both medicines, oral anti-hypoglycemics, but comparing SGLT2 inhibitors to DPP4 inhibitors. And what they found was that the SGLT2 inhibitors reduced your risk of heart failure, reduced your mortality, and probably reduced your risk of cardiovascular events and cardiovascular related death, right? And if you kind of looked at the subgroups, the groups that benefited most were cardiovascular events for women over 65 and heart failure events for men over 65 was the groups that benefited the most. And so I think this is good evidence for us to suggest that after metformin, SGLT2 inhibitors may be a good choice for a lot of our diabetic patients if they qualify. If this was looking at heart failure, and this was a phase 3 trial, looking at about 4,700 patients who had New York Heart Class 2 or worse with an EF of less than 40%. Their mean age was 66, 23% of these were women, and they really, they randomized these patients to dapagliflozin or placebo for about 18 months. And what they found was that the arm that had dapagliflozin, they had a reduced risk of worsening heart failure or cardiovascular death with a number need to treat of 21. And mortality was reduced with a number need to treat of 43. And interestingly enough, about 45% of these patients had diabetes at baseline, but the presence or absence of diabetes did not really affect the outcomes. So if you had heart failure but no diabetes, you still benefited from being on dapagliflozin. Looking at kidney failure, this was a meta-analysis, 4 studies, 38,000 patients. Those who are on SGLT2 inhibitors, they had a reduced risk of acute kidney injury, end-stage kidney disease, and this combined endpoint of dialysis, transplantation, or death from kidney disease was all reduced when on this medicine. The combined endpoint of loss of kidney function, end-stage kidney disease, death from cardiovascular disease or kidney disease was all reduced with a number need to treat of around 41. Interestingly enough, if your GFR was between 30 and 45, it was still okay to take this medication. It was okay if you had albuminuria, and it was okay if you were already taking a renin-angiotensin system blockade drug like an ACE inhibitor or an ARB. So really, it seems like a broad group of patients benefited from taking these SGLT2 inhibitors. And looking at canagliflozin and diabetic neuropathy, you can see this was 4,000 patients, followed about 2.6 years and stopped early due to success. And what they found was that those who are on canagliflozin, it reduced their risk of doubling of creatinine, it reduced their risk of end-stage kidney disease, and you can see here these secondary outcomes of reduced heart failure hospitalizations, cardiovascular death, MI, and stroke were all reduced by patients who are taking canagliflozin. So I know there has been some discussion around some of the risks of these SGLT2 inhibitors, including things like lower extremity amputation. And what they found was that in this trial, it was not really statistically different. The one thing I will mention, though, is that in every visit, they were doing foot exams on these patients. And if these patients had a diabetic neuropathy and were losing sensation in their feet, they were automatically taken off these medications. And so I do think that's something that is something for us to watch out for. A lot of our patients that are diabetics do have diabetic neuropathy, and they may not be good candidates for these SGLT2 inhibitors because the trials were specifically excluding these patients because of this rare but serious side effect. Finally, I will mention that these SGLT2 inhibitors are not cheap. You can see here that under Medicare Part D, the average patient was paying over $1,500 a year for these medications. And so it is something else to consider if you're working with patients who have financial difficulties. They may not be able to afford the cost of these medications, even if they have Medicare Part D because of their carve-out. Okay, is there another indication for colchicine besides gout? So what medications do patients get after a myocardial infarction? So we can go through these here. These are all really common things that we have seen prescribed. And the answer is, should colchicine be included in that group? And so this was a study of 4,700 patients. Their mean age was about 61, 19% were women, 30% were smokers, 20% had diabetes, and they were followed for about 2 years. And what they found was that the primary outcome of cardiovascular death, cardiac arrest, MI, stroke, or angina requiring revascularization was reduced with a number need to treat of about 62. There was no difference in overall mortality, but some of these other outcomes that I just mentioned were reduced. Now, in terms of side effects, nausea was increased with a number need to harm of 125. Pneumonia was increased with a number need to harm of 200, and flatulence was increased with a number need to harm of 250. So there were some side effects. Now, interestingly, leukopenia, which is something that we get worried about on patients who take chronic colchicine, was not increased in the colchicine group. So that risk seems to be not present, at least in this trial. So something to think about in terms of your patients who are recovering after an MI. Okay, are PPI safe and effective when used long-term? So Moyetti looked at this. So these were patients who were given pantoprazole to prevent gastroduodenal events. And interestingly enough, this is the COMPASS trial, 17,000 patients. These patients were taking dual antiplatelet anticoagulation for cardiovascular disease. The average age was 67, 79% were male, 61 had previous MI, 23% were smokers, and PPIs did not reduce GI bleeds in this group. It maybe reduced gastroduodenal bleeds, but the number needed to treat was very high, like 1,000, right? So the thought here was that maybe because this was a low-risk group, that this is why PPIs did not seem to prevent GI bleeds in this group. Now, what makes people high risk? There's lots of things, but classically the Rockwell score, which you can see here, does make people at higher risk. But I would argue many of my patients that I see don't quite fall into this category. And so, the thought that PPIs reduce GI bleeds may not be universally true for all patients, and that some risk stratification needs to occur to see which patients would really benefit. Now, in terms of safety, PPIs have been associated with all sorts of things, but Moyetti looked at this and really seemed to suggest that there was no increase in cardiovascular events, cancer, CKD, COPD, dementia, diabetes, fractures, pneumonia were all not significantly different in the group taking PPIs. The one thing that did seem to increase was that non-C. diff enteric infections increased with a number need to harm of about 250 over 3 years, right? I will mention that there was about twice the number of C. diff infections in the PPI group versus the non-PPI group, but that was not statistically significant. But I think whether you say it's non-C. diff enteric infections or enteric infections, including probably C. diff, that does seem to be increased in the group taking PPIs. Okay, what is the latest evidence on hormone replacement therapy and breast cancer risk? So a little trivia here. What does floccinaucinihilapurification mean? So I think the longest word in the English language, and it's the act or habit of estimating something as worthless, right? Or AKA the clinical breast exam, right? And so let's talk a little bit about this. So the American College of Physicians came out with their guideline about screening for breast cancer. And this is for average risk women, right? And they said the potential harms outweigh the benefits for most women aged 40 to 49. The recommendations were for biennial screening between ages 50 to 74, to stop screening at 75 or less, or if their life expectancy is less than 10 years. And that the clinical breast exam, as we talked about, is not recommended. This kind of matches what the CDC says, right? If you look on their website, it says if you're a woman age 40 to 49, speak with your healthcare provider about getting a mammogram. If you're a woman over 50, get a mammogram every 10 years. Right? Now, I do want to acknowledge when it comes to breast cancer screening, it's a very emotional topic. And if you look at the guidelines, there's a wide range of guidelines. So the USPSTF has recommendations, the American Cancer Society has recommendations, ACOG has recommendations, ACR has recommendations, ACP has recommendations, the AAFP. So there are lots of different groups who all look at the same data and come to slightly different conclusions. But I did want to let you know that the ACP recently updated their guideline to suggest that average risk women may not benefit from screening mammograms in that age group. Okay, menopausal hormone therapy and breast cancer risk. So this was a study looking meta-analysis by the collaborative group on hormonal factors in breast cancer. They looked at 58 observational studies, over 100,000 women. The mean age was 65. And their conclusion was all hormone therapy is associated with excessive risk for breast cancer. The estrogen progesterone therapy was worse than the estrogen therapy alone group, and yet your risk doubled if you used hormone replacement therapy for 10 years. The one caveat was that low-dose vaginal topical estrogen seemed to be okay and did not seem to affect cardiovascular disease, cancer, or bone fracture, and there really was no need for concomitant progestin therapy. The other thing we think about is the risk for Vino Thromboembolism. And this was a study looking at 80,000 women who had a VTE event in the UK primary care databases. Their mean age was 64. It was adjusted for comorbidities like smoking, BMI, a family history, and other comorbidities. And what they found was that if you were taking things like oral conjugated equine estrogen or estradiol, that you are at increased risk for VTE from hormone replacement therapy. Again, the one caveat here was that transdermal estradiol was not associated with the same risk. And so there may be a group of patients that would benefit from transdermal estradiol as opposed to oral equine estrogen or estradiol. Okay, and now for more controversial things, can we use HPV alone to screen for cervical cancer? So this was a trial looking at HPV only screening. This was 570,000 women from the UK cervical cancer screening program. And about a third or 32% were given only high-risk HPV testing. And what they found was that these patients had improved detection of CIN2 and 3 when compared to classical liquid cytology. And upon repeat screening, 3 to 5 years later, it was still better when compared to cytology. And so I think there may be a time in the future, right, when liquid cytology really is not used as much in in cervical cancer screening, and that really we are just looking for things like high-risk HPV in terms of determining people's cervical cancer risk. Now that we talked about that, could it be self-collection? Is self-collection possible, right? If the goal is just to collect cells for HPV examination, could a patient do that by themselves at home? So Pullman looked at this. This was 16,000 women in the Netherlands who were randomized to self-collect versus clinician-based sampling. They were followed for about 2 years. And what they found was there's really no difference in the rates of CIN 2 or 3. It did save the patient time and it saves healthcare resources. Obviously, the patient doesn't need to come into your office. It's one less appointment that you need to make. And obviously, you save on the supplies and everything that's necessary. But the bad things is that there was only a 9% participation rate, right? And so like most women opted out of doing something like this. And, we know from other studies, right, that maybe only 25% of patients chose self-collection in this other study from 2014, right? And that might lead to lower sensitivity rates in terms of collection. So, I think that when we think about population-based screening for cervical cancer, it doesn't seem like self-collection is the only thing that is stopping patients. So it's not the inconvenience or embarrassment or time or energy to come into the office to get a pap smear or high-risk HPV collection done. There is something else that is a barrier for women that we as a group of physicians need to get a handle on in terms of improving our screening rates for women. Okay, a few more topics here, and then we'll take some questions. How should we diagnose and treat ADHD? So the AAP came out with a new guideline related to this. We know that ADHD is more common, about twice as common in males and in females. You can see the prevalence here is somewhere between 7 to 15%, and then the mean age of diagnosis is 7 years old. And really, this new guideline emphasizes looking for things like emotional and behavioral conditions, anxiety, depression, oppositional defiant disorder, conduct disorder, substance use, developmental conditions like learning disorders or autism spectrum disorders, and physical conditions like tics or sleep apnea. So really the idea here is after you, in your evaluation actually, is to screen for these comorbid conditions, right? And then you can see here, in terms of treatment, it really depends on the age. When kids are younger, 4 to 6 years old, really a lot of this is related to parent training and behavioral class interventions. And then as patients get older, into the 6 to 12 range, that's when medications become more common in terms of part of a treatment plan for these patients. Okay, I didn't want to mention this. Lambez looked at this, and this was 18 studies, a meta-analysis looking at non-pharmacologic interventions for ADHD. And you can see here the interventions were cognitive behavioral therapy, cognitive training, neurofeedback, and physical exercise. And the outcomes that they were looking at were attention, inhibition or focus, flexibility, working memory, and higher executive function. So interestingly enough, physical exercise was the intervention that performed the best. And the outcome was focus. And so I'm going to list here, the effect sizes. And you can see here that all of these interventions had sort of medium to large effect sizes. So I think for our patients with ADHD, right, I think this is great news that, medications is not the only option, or on top of medications, there are several things they can do, which include CBT, cognitive training, neurofeedback, and the physical exercise. The best thing they can do is to be physically active. And that the outcomes here as listed below all improved, but really the idea is that focus seemed to improve the best. And I will mention the physical exercise was not, 3 hours every day outside. Some of these trials was as little as 30 to 90 minutes, 1 to 3 times a week. So it can be kind of what we consider to be normal sort of physical function, right? Or normal physical exercise, getting out, running around, playing together, exercising can be beneficial for patients with ADHD. Okay, is there a way we can reduce risk of autism? Maybe. So this is a study looking at 241 younger siblings of kids who had an older sibling diagnosed with autism spectrum disorder. This was 3-year follow-up. And what they found was that prenatal vitamin use started within the first month of pregnancy seemed to reduce the risk of a subsequent child with ASD with a number needed to treat of 5. And especially things like higher folic acid levels and iron intake were associated with lower risk. So I do think that this is something important for us who, as primary care doctors, we do a lot of counseling, especially around prenatal care and getting ready to start a family or to grow a family. And so I think in that case, encouraging patients to be on a prenatal vitamin, to focus on folic acid and iron intake as a way to reduce their risk, especially if they have a child already with autism spectrum disorder, I think would be good advice for us to give. Okay, finally, how do patients feel about doctors asking about firearm safety? So this was a trial looking at, actually not a trial, sorry, this was a survey of about 2,500 Californian who were given a survey about firearms and their physician asking about them. And you can see here, about 67% of respondents said it's sometimes to always appropriate to discuss gun safety. And then 41% of gun owners, so not everybody in the survey was a gun owner, but 41% of gun owners said it was never appropriate to discuss something. But that means that the majority of even gun owners thought it was appropriate to sometimes to always talk about gun safety in a clinician visit. Now, you can see here the appropriateness increased to greater than 83% in the following scenarios. So if the patient has trouble with drugs or alcohol, if the patient has suicidal thoughts, if they have dementia or lives with someone with dementia, or if they live with kids, right? All of those situations caused the survey respondents to say it is more appropriate for the doctor to address the issue of gun safety. And then finally, what did they said, what is the good interventions that your physician can do if they are concerned? And they said general counseling, like don't hurt yourself, giving the gun to someone else, but also informing family, police, or behavioral health professionals around the risk for this patient were all considered to be appropriate action. So, I know talking about gun safety can be potentially a touchy subject for some patients, but at least in this survey, it seemed like there were certain situations, especially where most survey respondents thought it was appropriate for their physician to address the issue of gun safety. Okay, what is the financial cost of physician burnout? So this is a very relevant topic, something that we talk a lot about. And there are so many important aspects to physician wellness and burnout. And I don't want to reduce the discussion to a discussion about finances only, but this was a study that looked at finances, and so I just wanted to mention it. The numbers shocked me, right? $4.6 billion every year due to physician turnover and reduced clinical hours. And that, basically, if you are in an employed practice or you own a practice, we're spending close to $8,000 every year related to burnout costs. And so if you're in a 13 physician group, you're losing $100,000 every year related to burnout. And that you can see here, the burnout prevalence and the majority of interventions is reduced clinical hours. And so you can see here in the group that is greater than 55, almost 40% of in primary care, this is primary care data, about 40% of the physicians were planning to reduce the number of clinical hours they are working related to burnout. So I do think that this is something for us to consider in terms of how best we can support each other and lean into our faith and other things that can help us stay well, especially during this past year, which has been so difficult for many of us to manage. Okay, weight loss, possible in primary care setting. This is a trial looking at primary care. I love this because it's outpatient. This is primary care. This is 300 diabetic patients. They're diagnosed in the last 6 years. They were not on insulin. Their average A1C was about 7.7, and they weighed about 100 kilos at baseline. And basically what they did was a very intensive 850 calorie diet for about 3 to 5 months, and with stepped food introduction. And what they found was about a number needs to treat of 11 for a 33-pound weight loss. And diabetes remission was a number needs to treat of 3. So 1 out of every 3 patients was able to cause diabetic remission or reversion. So really great data. And about 24% were able to maintain at least 10 kilo weight loss at 2 years, right? Now the challenge is, what is 850 calories? Not a lot. And so this is just a sample I found online. This is not what they did in the trial, but if you were thinking, okay, I'm just going to eat 850 calories a day, what would that look like? And you can see here, this is an example of what an 850 calorie diet might look like. And so it's pretty restrictive, right? And so you'd have to really get the patients to buy in. But I like this trial because it's primary care. It was done not in a specialist office, but really with primary care doctors thinking about how best we can help our patients with weight loss and diabetes reversion or remission. And then finally, is breakfast golden, right? This is a trial looking at 13 meta-analysis, 13 trials, about 1,400 patients looking at breakfast eaters and non-breakfast eaters, right? And what they found surprisingly was that breakfast eaters consumed 260 more calories during the day and weighed about 0.5 kilo more. And so I know classically we say, well, if you eat breakfast, you'll be less hungry during the day and you're less likely to snack throughout the day, right? But that doesn't seem to be true, at least not in this trial. And I know, nutrition trials are very hard to organize and standardize, but what they did find was that people who did eat breakfast, they were more physically active during the morning, and that their overall thermogenesis was probably unchanged, but they probably were more physically active in the morning. Yes, breakfast eaters consumed more calories and weighed 1 kilo more. Okay, and finally, is there neurologic benefit to aerobic exercise? So certainly we would say that's true. There's 132 patients, average were 40 years of age, 70% were female. They were randomized to aerobic exercise versus stretching. And what they found was there was a small improvement in executive function and reduced BMI. But you can see here no effect on things like attention, memory, language, or speed. Part of the trial that's difficult to interpret, there was a high dropout rate of about 20%. And they did do some MRI studies, but those aren't really patient-oriented outcomes, so I'm not going to talk too much about that. But I think we know that aerobic exercise has wonderful benefits for us all, and it's nice to know that there are some studies that start to validate what we kind of intuitively know to be true. Okay, so with that said, I'll just say I'll stop here. I appreciate your attention. We covered a lot of different topics. Thanks for sticking with me. We'll stop here. I do want to mention here that all our references are going to be available. So any of the things that I mentioned that you say, that's very interesting, I want to read up more about it. The reference for it is available here. Okay, with that said, thank you very much for your attention, and I'll stop here to take some questions.
Thank you very much, Hobie. Appreciate your time in preparing that. I feel vindicated in my supposedly poor habits of not eating breakfast now. I will mention that there are some studies, fairly good studies from Harvard, that show that individuals who consume the majority of their calories before 3 p.m. actually were more successful with weight loss. But it's an interesting take on breakfast. So Hobie, I don't know if you can see the questions that came in or not, but I'm going to read a couple of comments. There's 2 here that are same theme, and I'm going to ask that you respond to those comments. And then also, if during Dr. Lee's response, anybody has additional comments or responses, if you could quickly type those into the live Q&A, that would be nice as well. This is just to try to get some dialogue. We're missing the dialogue with the virtual event, but we'll do our best. So comments, HRT, and then too bad you didn't differentiate CEE/progestin versus oral estradiol and progesterone, because there's a large difference. And then same point, the Women's Health Initiative revised data showing that estrogen alone in women after hysterectomy had lower breast cancer risk. The increased risk was with those women taking estrogen plus progestins. Comments on that?
Yeah, so can you hear me, Dr. Riker? I just want to make sure. Yep. Okay, perfect. So those are good comments. I would say HRT, hormone replacement therapy, is a very tricky subject. And I would say every few years, there is another big analysis that is done talking about the risks versus benefits of estrogen and or different types of progesterone, because we have different generations of progestins to give patients. And so I think that data, I think the comments are well taken. And what I would say is that for us in primary care, I think a lot of my patients come requesting to be on hormone replacement therapy because they just assume that's the right thing to do, or they need it entering perimenopause or menopausal states. And I think it just requires us to have a little bit more of a nuanced conversation with our patients and to say that these medications are not without risk. And that, one of the fundamental questions always is, should a 60-year-old female have the estrogen levels of a 20-year-old female, right? Because that is what we're trying to essentially mimic for some time. And the answer may be yes or no, right? And it really depends on the patient. And so I just think that for me, it just is a reminder for me to look at the evidence and to take the time to have that conversation and to mention that there are some risks associated with HRT, and it's not just a benign, take some hormones for a few years to kind of help you through the perimenopausal phase.
Another question, is my question actually, with when you're talking about PPIs, there was a statement that non-C. diff infections were more common. What specific infections are you referring to as non-C. diff infections more common in people using PPIs?
Well, they were just gastroenteritis infections. So these are, just, I don't know the specific bacteria that were isolated, but they did look at C. diff versus non-C. diff enteric infections. And unfortunately, or fortunately, C. diff was not statistically different in the PPI group. But I will tell you that numbers needed to, the number of C. diff infections were small. I mean, these were just a few numbers in both categories of the PPI and non-PPI group. So the power may have been too low to really detect a difference. But I do think that for certain, we can say that non-C. diff enteric infections seem to be increased in a PPI group. And that is something to consider with your patients, especially for those who might be at high risk for something like that, to think about whether PPIs continue to be beneficial to your patients. The whole point of all these discussions, I think, is there is a risk-benefit profile for all of these things that we do. And I think patients tend to look at the benefit and don't always consider the risk. And I think our job as primary care physicians is to help them navigate that and to really give them information so they can decide what risk profile is acceptable to them. So some patients might say, this is fine, it's not a problem, I really need my PPI, and that's fine. And other people might say, man, I didn't realize that, and I don't know if I really need this, or the risk seems too great to me. And I think that's fine too. But I think we have to give the patient some autonomy to understand what those risks may be and to help them give them information so that they can make a decision with that.
So a couple more questions about statin therapy. Should we be taking our patients off their statins once they hit that 70th birthday to decrease polypharmacy, other potential risks of using the medication? What's your opinion?
Yeah, so that is a tricky question. What I would say is that there is evolving data around this. And even as I presented data, there are other published data that supports maybe benefit in primary prevention higher than age 70. So I'm not sure it's totally clear when the right stop point is. But again, I do think that this is a worthwhile discussion to have with your patients, right? That primary prevention model suggested that in a male who's 70 years old, their 10-year risk really needs to be above 21, 22% in order for benefit to occur. And so if your patient has an ASCVD, which is less than that, and they really don't like taking medicines, or the medicines are too expensive for them to continue, or you're having adherence or polypharmacy issues, I certainly think it's a worthwhile discussion to say, this might help you, it may not. And the data probably is pointing towards no here. Are you willing to take a small increased risk of a heart attack or stroke to not have to take an extra pill, right? Or to not have to deal with occasional myalgias, or for us to keep measuring your LFTs, or whatever the consequence might be. And so I just think the idea that, a statin primary prevention, again, not secondary, but primary prevention, never had a heart attack or stroke, never had cardiovascular disease of any sort, or any kind of vascular disease. The idea that you take a statin, you take it until you die, I'm not quite sure we're there. And I'm not sure that the data would support that either.
Dr. Lee, thank you so much for your lecture, for presenting some evidence and allowing us the opportunity to think about it, and for challenging us to go back, look at the data, look at all the data, look at all the studies, and really try to practice an evidence-based style of medicine. So thank you very much, Dr. Lee.
It's my pleasure. It's wonderful to be with you all.